All right, let's talk about one of the biggest challenges in the ER, the acute abdomen.
So your patient rolls in with severe belly pain. The clock starts now.
And the big question is, medical or surgical? That one decision changes everything.
Having a solid systematic approach is key, so let's break down how to do it. Just to give you some perspective, the CDC says almost 7% of all ER visits are for abdominal pain.
That's a pretty wide net, right? So we have to be systematic to find that surgical abdomen fast.
It all starts the second they come through the door. A good history is everything here.
These questions are your bread and butter. They build that initial differential diagnosis for you.
This is a great example. The story of the pain, how it moves, tells you so much.
Okay, now for the hands-on part. The physical exam is where you find those major red flags. If you find any of these signs, well, that's peritoneal irritation. Time for an urgent surgical consult. And knowing the difference between visceral and parietal pain, that's how you track what's happening inside. All right, you've got a theory. Now it's time for labs and imaging to see if you're right. An algorithm like this gives you a clear roadmap to follow, all the way from exam to OR. You see a lot of possibilities, but the data is clear. These three are the usual suspects. This is a great cheat sheet, really. It breaks down the classic signs for common surgical problems. And this is a huge takeaway. You have to keep this one in mind. It can be absolutely catastrophic. For a small bowel obstruction, these are your first critical moves to get the patient stable. Okay, so you've found a surgical cause. Now the game changes from diagnosis to action. It really boils down to three things: stabilize the patient, get consent, and get the team on board. So now we go beyond just the diagnosis and into the art of really talking to our patients.